Director of Integrative and Metabolic Medicine at the George Washington University, as well as the Director of Medical Education for the Metabolic and Medical Institute. This is a partnership that has been formed to deliver excellent education and curriculum for integrative medicine. And we have a very exciting weekend coming up at the end of October, October 31st to November 2nd. And today, I'm very excited to speak with Dr. Kelly Brogan. She's an integrative psychiatrist who practices in Manhattan. She's a leader in her field, and we are delighted to include her as part of our educational programming. She has done a lot of work, especially in the area of mood disorders, and taking a broader view on how to understand and better treat patients who suffer from those sorts of issues. So thank you, Dr. Brogan, for joining us today.
Thank you. It's a total pleasure.
So tell me a little bit about your background and how you got involved in this field in the first place. Every physician or practitioner, I think, has a story in that regard where they make this transition from, conventional practitioner to, broadening your toolkit and really looking for other solutions that aren't often offered through the conventional approach.
Absolutely. I've always been interested in women's health. I sort of joke that I might have been born a feminist, and so I chose to pursue what's called perinatal or reproductive psychiatry. It's really a burgeoning field, even when I was coming into it, whatever it was, 7 or 8 years ago. And I felt that it was the best way for me to truly get to know my female patients as a psychiatrist, for example, rather than an OB, and actually to advocate for them, their well-being, and their more comprehensive sort of life experience. And I think I got pretty good at psychopharmacology. I was very interested, and I think, lured in by this notion that I could master behavior through, pharmacologics and through what I thought I understood about this brain-up approach, sort of head-up approach to mental health. And when I started to focus, clinically on the demographic that included pregnant and breastfeeding women, I just started to feel very limited by this sort of dichotomous approach of talk therapy or medication and helping to consent women around taking medications during pregnancy and breastfeeding is something that I spent, 2 years of training, to develop expertise in. But there were many women who opted not to, despite, my efforts to reassure them with the available data, and I had nothing else to offer them. So that's when I took on an interest in evidence-based alternatives and complements, things like B vitamins and fish oil. But I even felt, somewhat limited by that ultimately, and it was even in developing, as you said, everyone has their sob story, right? And mine was developing postpartum thyroiditis after my first pregnancy, so Hashimoto's, and that was my entry into the sort of more, I guess, systemic functional medicine, however you want to term it, to that arena where I really was determined to put this autoimmune condition into remission. And it required a deep appreciation for and understanding of the gut microbiome. And so through my own experience, I started to learn about that, learn about how to modify it through lifestyle. And I've taken that knowledge, I guess, and of course, thousands of hours of training, reading, and research into my practice. And I get, outcomes clinically today that I don't think I ever could have achieved through the conventional route, and it feels very gratifying, incredibly so.
And tell me a little bit more about that sort of intellectual breakthrough in a sense. It sounds like in some ways what you're talking about is this relationship between the gut and the brain. And it really gets to this notion that we're trying to convey through our new training program, and that is this sense of systems biology, that systems talk to each other. And that illness doesn't necessarily reside in one organ and one organ alone, but in fact, we have to sort of broaden our thinking with regard to looking at these sort of molecular and systemic interactions that are occurring. So tell me a little bit about that gut-brain connection and how you think about it and how you basically approach it in your practice.
Yeah, so it's exactly as you've described, and I think there was very recently this week a description of the first ever reversed case of Alzheimer's, right? And it was through the systems therapeutics, they call it, which is essentially exactly what you're describing. It's a multimodal approach that acknowledges the interconnectedness between the endocrine system, the immune system, neurochemistry, and the gut. And through my lens, the gut microbiome, it seems to be where we have outsourced the vast majority of our biochemical tasks and requirements and needs since the completion of the human genome and our discovery, this anticlimactic discovery that we are not actually, our genes are not sufficient to explain our complexity and also our pathologies. So it's such a massive control center, for our biology that it's very hard to not include it in the equation. But I even feature it more centrally, and rather than wait, what is the 17-year lag from what's in the data to what happens in the doctor's office, there's such an incredible amount of relevant information in the literature now that we can operationalize. And, when it comes to the microbiome, I mean, I probably read 3 to 4 papers every day about it, and I find it very exciting. In the realm of psychiatry, the term is being used, psychobiotics, so this notion that there are therapeutic grade probiotics that can be used to influence clinical outcomes, whether it's anxiety or depression, even OCD. And we are really leaning on about 2 decades of animal and now beginning to trickle in clinical research that has demonstrated to us that there is a bidirectional relationship between the gut and the brain, and that communication happens primarily through the immune system. And it wasn't that long ago that we didn't even know that there was an immune system in the brain. We thought that that was only in the case of pathology or trauma or injury that there would be immune activation in the brain. And now we know that this is sort of part of the day-to-day experience of living, that your brain is a very active immune organ. And I sort of take it, it sort of seems to dovetail well with my interest in perinatal health, to focus on the origins of the microbiome. And, my thinking is that when medicine began to take a more mechanistic approach to the human body, we sort of relinquished an appreciation for the unseen, for our sort of fundamental connection to this ecology of microorganisms and plants and animals. And I really think many different DSM-based diagnoses, we've started to say, okay, so I don't think we've gotten it quite right, and based on what we've learned about epigenetics and this, rapidly increasing incidence of mental illness, slated to be the world's, most prevalent form of disability, we have to go back to the drawing board. And so one of, in the literature, the most prominent theory, again, that's been cropping up over the past, since the early 90s, is called the cytokine theory of depression, although, again, it has been explored in many other pathologies, really exposing that these pathologies, whether it's schizophrenia or bipolar or OCD or panic disorder, are illusory distinctions, and that they probably have many different paths to what is really a descriptive, sort of more like epiphenomenon. And so the research has really focused primarily, if I were to pick 2 cytokines, it would be interleukin-6 and TNF-alpha, demonstrating that they are linearly related to mood states, so specifically depression. So, the higher levels relatively that you have in your serum, the more clinically depressed you appear. And this has been sort of grounded by the work of some very important, researchers, Mays and Charles Raison and others, who have helped us to understand evolutionarily why this might be the case. Why depression and associated behaviors like anorexia, anhedonia, withdrawal, decreased social contact, why these might actually have been an adaptive response to perceived bodily stress or threat, to slow us down, bring us into a place where we can actually, sort of heal and then get back to, the business of living. And so there's, been demonstration about how these cytokines actually can not only traffic from systemic areas in the body to the brain, and it's sort of been elucidated several different ways that that can happen, but then even what happens in the brain and specifically in the microglia once the cytokines have transmitted their message, and how even the catabolism of amino acids, so tryptophan, for example, is influenced once this activation is happening in the brain. And I think it's very exciting and explains in many ways why stress can actually result in neurotoxicity, and how it is that the stress response hormones like cortisol can participate in actually allowing that to happen. But then, of course, the question always is left, what is causing the stress? What is driving the stress? And that's where, it can be a broad range of answers, from environmental toxic exposures to infection to food antigenicity, metals. It can be a long list, and that's where the personalization comes in, so that, the root cause can actually be reversed.
I think you've been very articulate in beginning to describe the architecture that I think underlies a lot of disease states where, in fact, they sort of escape a really good diagnosis, and we tend to sort of slap labels on people. And this happens across sort of mood disorders, cognitive decline, but also sort of these wastebasket terms of chronic fatigue and fibromyalgia and irritable bowel, where we have some clinical diagnostic criteria and maybe some biological their symptoms improve, and then this marker does improve. So it's widely available. It can be indicative of sort of general body inflammation. Of course, it's highly nonspecific, but if it is trending downward, you probably can assume that what interventions you have engaged are having something of the desired effect. But I'm also interested in other sort of like evidence-based correlates of altered mood states, whether it's depression or anxiety. And so this very much encompasses subclinical hypothyroidism, Hashimoto's, Graves' disease. So I'm very interested in doing a broad screen for that. I also look at vitamin markers, but specifically B12, and of course we could debate about the validity of a serum B12 level, but I do use it as, sort of, I guess the foundation of my decision to sort of step in with injectable B12, which I use in almost all of my patients. And again, in psychiatry and in sort of, I guess, neurological health, we have precedent for understanding that B12-related dementia, but also the other B vitamins, whether it's thiamine or niacin, can manifest psychiatrically and can be reversed with repletion. So I'm very interested in sort of like entering at the level of, sort of soft diagnoses, I guess, that I can sort of quickly turn around, primarily with diet-based changes. And of course, treating women in my practice, I'm very interested in the role of dysglycemia in what we are calling mental illness in this demographic. I think the women are particularly susceptible to things like reactive hypoglycemia. I've certainly been there myself, the way I was eating when I was a resident and fellow. And I know that it is something that can be reversed with, particular dietary changes. And so we can see that in, I don't typically do glucose tolerance that frequently, but you can triangulate fasting insulin, glucose, fructosamine, and hemoglobin A1C to see just how much sugar is causing problems for this patient. And of course, thanks to folks like David Perlmutter, we have a good understanding that this could even be considered preventive medicine, treating patients in their 30s and 40s with an eye towards balancing their blood sugar. So that's, I think, a broad view. Right. Well, and I think, what you've mentioned is really a step forward in the field of psychiatry. And it's curious that as a discipline, there's very little attempt at sort of objective measurement of the patient that's sitting in front of you. It's more so that DSM-4, DSM-5 process of what do I think their clinical symptoms are, and what's the label that goes with that, and then what are the drugs that go with that label.
Right, very impressionistic.
It is, and subject to all sorts of bias and debate. But I think what you're describing is that it sounds like the field is really moving forward, and the work that you're doing and that others are doing. It really it's the new medicine, and I think for all of us, myself, and I'm sure yourself included, now as part of George Washington University faculty, we are going to work very hard at uncovering what these underlying links are. And when you look at the lineup of faculty that we have speaking over the course of the weekend, Dr. Fasano from Harvard, Dr. Lee from Hopkins, Dr. Burdett from Dunwoody Labs, it's all really focusing on new advances in understanding the gut and gut-immune interactions. And then the work of Richie Shoemaker and Tom Williams, taking a very deep dive into the immune system proper, both on the acquired side, which I think everybody spends time with on T cells and B cells and antibody production. But I think Dr. Shoemaker's work has been really critical in uncovering what occurs within the innate immune system.
Innate, yes.
Very advanced, which I think is a whole new area that's incredibly important, with new measurements like TGF-beta1 and C4A and C3A and MSH, which are critically important for brain health and really sort of whole body health in general. And then finally, the contributions that you'll be making in terms of this broader model of integrative psychiatry, but that will stand next to Dr. Duckworth and his work in the military on traumatic brain injury. And there's this sort of, as you said, triangulation that's occurring between external injuries and what I would consider internal injuries to the brain. And the sort of final common pathway of what happens to the brain under these multiple assaults, and how much sort of either functional changes or true organic damage is occurring, both because of gut-related issues, but probably more importantly, immune activation. And now we're understanding through QEEG and functional MRI and SPECT scanning and neuroquant, we're much better able to characterize the changes that are occurring in key areas such as the putamen and the caudate nucleus and the locus coeruleus and others. And so this model that we're trying to build collectively through this incredible group of experts, and certainly yourself included, I think is really, really exciting, and something that I haven't seen before, even sort of in our own field, sort of assembling this group of experts that have this view. I'm excited to learn. And,
I was just going to say that. Yeah.
So anyway, so I don't want to take up any more time. You've been delightful, and I know we're really, really excited to have you involved and join the faculty at GW and participate in this new MMI programming. I think this is the start of something really special. So thank you for taking your time, and I look forward to seeing you in a couple weeks.
Thank you. I'm honored, truly, and incredibly excited. I can't wait.
Okay. Take care.